And let's get to the last one out of these, and that's the purely, or rather, not purely, but rather glomerulonephrosis problem. So, glomerulonephrosis. So, not too much of inflammation, or in other words, non proliferative glomerulonephritis. Okay. So, and it's non-proliferative. So again, the number of the cells in the glomerulus is not multiplying. It stays the same. But we're going to start right away with SLE. And I will rather place it here because, yeah, with SLE, you can have really nephritis or nephritic or nephrotic syndrome. But most of the cases, if we take them all together, it's going to be rather like really slight SLE. So rather put them in a nephrotic, but really easily you can have a nephritic syndrome, so nephritis. And with the SLE, so this SLE covers everything. So again, nephritic could be, but over here we're mentioning it as a rather nephrotic problem. Nephrotic problem, okay? And how do you diagnose that? Well, as you know, it's very easily clinically diagnosed. If it's the nephrotic problem, you're going to talk rather about glomerulosclerosis. And if you have glomerulosclerosis, you're going to end with end-stage renal disease, so with a transplantation, if you are lucky enough. And anyways, what you look for in the blood, well, of course, you're going to look, I'm going to put them in green. So antinuclear antibodies. So in this case, if it's antinuclear, this is a cell membrane, and the whole nucleus is going to shine, okay, of any cell, because it's antinuclear. So a 99% of SLEs will have this antibody, although it's not necessarily only SLE. And the other one is anti-double-stranded DNA. So against DNA, double-stranded DNA, it's not so high percentage. I don't know, 70 maybe, I'm guessing now, but it's also, if you have both of these antibodies and a butterfly rash on your face, it's SLE. And if you're losing proteins to it, it's the nephrotic SLE. Okay. But with SLE especially, you anyways will, although you are pretty sure with the diagnosis, you're going to do biopsy because of the treatment. Because you want to know if glucocorticoids are enough, or if you have to combine it with something more toxic like cyclophosphamide. Okay, so remember, biopsy for treatment. Corticoids plus cyclophosphamide. Okay, and really you can have really nice versions of this, not dangerous one, and some really can do the RPGN as well. Okay, so in nephritic RPGN. So crescent glomerulonephritis. Okay, so that's SLE, that's special one. But then all of the other ones are really rather nephrotic problem. Okay, so which one? Well, amyloidosis. I'm going to put it in yellow. So amyloidosis, and you love it. And most common one is thanks to multiple myeloma, of course. So multiple myeloma. That's the most common version. So AL, amyloidosis, but of course any chronic inflammation, so can cause the other type of AA amyloidosis. So basically rheumatoid arthritis or inflammatory bowel diseases or any kind of chronic diseases can cause amyloidosis, and that's why the amyloid will be stored very likely in the kidneys, and that's why you're going to have nephrotic syndrome with amyloidosis. So I'm going to put rheumatoid arthritis, inflammatory bowel disease, and etc. etc. Remember, over here, Congo stain is the answer for pathologists, and what is even more important is the apple green bifringens. Okay, so remember, that's apple green. I'm going to write it like that's what the pathologist will want you to say, bifringens. Okay, so apple green bifringens. Okay, that's crucial. This is more important than it's Congo bifringens is diagnostic. Okay, so that's amyloidosis. Another cause, and you know this is the most common cause in the world, it's diabetes mellitus plus hypertension. It's because these two go together. So most common cause is nephrotic syndrome. Although, as I said, to see a diabetic with a nephrotic range, proteinuria, no chance. Diabetes is the most common cause in the world. That's why it's the most common cause. But you as a individual doctor, with diabetic patients, you'll typically see some microalbuminuria or proteinuria. Occasionally, really rarely, someone could end with nephrotic syndrome. Okay? Remember, on sonogram, the kidneys are bigger. Okay? So, nephrotic syndrome, of course, nephrotic and large kidneys on sono or CT or whatever you want. They're just large. Okay? Remember the microalbuminuria. This is what you monitor the patients. This is why you give them ACE inhibitors already. Then the worst is proteinuria, and only few could end with nephrotic. Rare, but the most common cause in the world. Most common. Another example is the minimal change disease. That's the most common in children, most common cause of nephrotic syndrome with children, and you diagnose this only on electron microscope. That's why it's minimal change. Okay. In contrast to this, we got this, let's say, Molotov cocktail, which causes everything in the kidneys. It can cause anything you want, and those are non-steroidals. Because they can cause, as we talked about earlier, they can cause acute kidney injuries because of the direct toxicity to the tubules. They also cause vasoconstriction of the afferent artery, so ischemia to it. And also they destroy the glomerulus, and they can also cause minimal change disease. Or they can cause membranous glomerulonephritis. So although it's nephrotic syndrome, they call it glomerulonephritis, but watch out, the term nephritis is misleading because this is a non-proliferative process, okay? So rather, please think of it as a slight inflammation, and that is also why they use a newer term which is called membranous nephropathy. And this is a better term because this stresses that it's rather non-inflammatory so much. Okay, so in books you'll find both terms. You can find membranous glomerulonephritis, but nowadays in the newer books, newer texts, you will rather find a term membranous nephropathy. So remember the nephropathy. I'm going to write it down over here. So nephropathy. Okay. So remember membranous nephropathy is the newer, better term. Okay. So that's non-steroidals, and then rather a general point of view for you. Remember, also cancer. If it's any kind of solid cancer, remember, you can also see membranous glomerulonephritis. So although we don't know the mechanism exactly, some people with cancer, solid cancers, they can have nephrotic syndrome thanks to membranous glomerulonephritis, okay? And then remember also you could have a question on HIV or drug addicts, because they're injecting themselves with, impurities, and this can also destroy the kidneys, and they have the focal segmental glomerulosclerosis. So again, they can have a nephrotic syndrome or some kind of a protein loosage. With the focal segmental, don't forget the Alport. I will put it here. Alport. That's the focal glomerulosclerosis as well. And the last one, this is very rare, but sarcoidosis can also, in some cases, and it's rare, can cause nephrotic syndrome. Okay, so again, sarcoidosis. And the main thing about sarcoidosis are lungs, of course. And remember, with sarcoidosis, if I should repeat it, either you look for non-caseating granulomas in the lungs, they can have a nephrotic syndrome. And definitely what they will have is problem with calcemia. Remember, they can have hypercalcemia. So if someone asks you about these three things, and especially, lung problems and hypercalcemia, and maybe some nephrotic syndrome, remember it's sarcoidosis, okay? So those were the cases of mainly non-proliferating glomerulonephritis, okay? Yeah. Questions?
Can we go through the NSAID damage again?
Yeah. So with the non-steroidals, just remember non-steroidals are bad. First of all, they block the production of prostaglandins. So they will cause vasoconstriction of the afferent artery. Then we know they're toxic to the epithelial cells of the tubules. So they kill them somehow as well. So this is a double hit within the acute kidney injury thing. And then even more, we know that it can destroy the glomerulus as well. So basically when you're getting old and the function of your kidneys is decreasing, don't take non-steroidals if you don't have to. Don't do it. They're toxic to the kidneys. And even more, as I told you last time, but I don't know if you were there, guys. I don't know who was there. Remember, if you're having, for example, sickle cell disease, that's going to be in USMLE, and you take non-steroidals to it, you will send an atomic bomb to your kidneys. And what will you have? What do you call that? Papillary necrosis. That's the end. It's an acute kidney fail that leads to transplantation right away, because the part of the papilla will just get necrotic, and that's the end for the kidneys. If all the papillas die, as I said, you have 10 or 16 papillas in your kidneys. If all of them get necrotic, you can throw out the kidney. So don't combine the mechanisms, okay? So we ended with glomerulosclerosis. Now you're gonna love it. So thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.